you so much for having me here. It's a pleasure and it's an honor to be with you today. And I hope that the technical part will also be successful. Then we can start. The lady is responsible for the technical. Okay? Thank you. So, I will give 2 talks this morning, and I will start with the cardiovascular complications of thyroid disorders. I will try to be clinically oriented because I've heard that the majority is working in the clinic or in the practice. But if you have more questions regarding basics, I will be happy to answer. So I'll go slowly, hoping that you can understand me. And if you have problems with my language or with the speed of the talk, please give me a sign. All started 15 years ago. This is one of the first studies published in The Lancet, telling you that the cardiovascular mortality is increased in patients with hypothyroidism. The mortality is increased and the cardiovascular mortality also, threefold. This is the group with a TSH below 0.5, and these patients are euthyroid. So this was a big question mark. At that time, I remember, I was in the United States. And the person who presented the data at the American Thyroid Association was actually heavily criticized because the people would not accept this. I was at the American Thyroid Association and the people would say, why are you telling this? This could not be happening. Thyroidism is a benign disease. So you are telling us that the people are dying of hypothyroidism? No. Impossible. And it has been reproduced. And it has been reproduced several times, showing you that even patients with subclinical hypothyroidism, subclinical, meaning that TSH is suppressed, but T3 and T4 are normal, is also causing increased cardiovascular mortality or mortality as a whole. So we had to learn and we have to rethink, especially those patients older than 60, 70, 80s are the risk patients. So just a suppressed TSH of below 0.1 will increase cardiovascular mortality. And why is this the case? Because the cardiovascular events, myocardial infarctions, angina, arrhythmias, are all increased. So these are the cause why cardiovascular mortality is increased, leading also to overall mortality. And this is a table, a meta-analysis showing you the increased hazard ratio. Above 1 means that the risk is increased. Are you following me?
Yes.
So let's go into detail. If we are talking about atrial fibrillations, and you see that the hazard ratio is increased, how can you explain this? If you look at the next slide, this shows you, can you dim the light, please? Is it possible to dim the light? Because I have very clear slides. You may look at the prevalence of atrial fibrillations, which is 15% in patients with overt hypothyroidism. Overt means TSH is suppressed, T3 and T4 are increased. the prevalence of atrial fibrillation in subclinical hypothyroidism is nearly similar. So between subclinical and overt hypothyroidism, the risk of atrial fibrillations is nearly similar. And in contrast to controls, the risk of atrial fibrillation is increased by fivefold in comparison to controls. This explains why in the patients with subclinical hypothyroidism, you have a high risk actually of cardiovascular mortality. This study has been performed in more than 25,000 people from Australia. We have also actual data from 500,000 people, more than 500,000. Also looking at the risk of atrial fibrillation in overt hypothyroidism, subclinical hypothyroidism, euthyroidism, subclinical hypo, and overt hypo. And the bottom line is the highest risk for atrial fibrillation is similar between overt and subclinical hypothyroidism. Look at these lines. Comparable. This is the cumulative risk for atrial fibrillation. 500,000 people. And the lowest risk for atrial fibrillation, patients with hypothyroidism. Okay? So if you have atrial fibrillations, independent if you are 50, 70, or 90 years old, if you are female or if you are male, the risk for death is twofold increase. And the risk for emboli and strokes is increased sixfold. Okay? This also explains why cardiovascular mortality and overall mortality is increased in patients with hypothyroidism. The platelet coagulation is also increased in hypothyroidism in comparison to euthyroidism, meaning that the risk for emboli and thrombosis is increased in hypothyroidism. This is also increasing the cardiovascular mortality. In 50% of the patients with hyperthyroidism, you see that the myocardial tissue is showing a hypertrophy. You have growth of the myocardial myocytes. This is reversible in contrast to acromegaly. The weight of the heart is usually 300, 400 grams. And here, in hypothyroidism, the weight may approximate 1 kilo. In acromegaly, it approximates 1.5 kilo. And the risk for mortality, for cardiovascular mortality in acromegaly, is mainly due to this actually increased growth of myocytes and of myocardial structure. In hypothyroidism, luckily, fortunately, this is only reversible. If you treat the patients, the hypertrophy will go back. And we do know, and I have learned this from the cardiologist, that hypertrophy of the myocardium is an independent risk factor for cardiovascular mortality in men between the age of 40 and 60. So, cardiovascular mortality is mainly also due to differentiation, to changes of the structure of the myocardium. And T3 is a direct stimulator of myocardial growth. The growth of the myocardium leads also to an increased risk of arrhythmia, both supraventricular as well as ventricular arrhythmia, especially in older patients with nodular goiter. We do see arrhythmia in patients with Graves' disease, but it's especially in patients with nodular goiter. Why? Because in Europe, patients with nodular goiter are older than patients with Graves' disease. This is usually the case. So they have also more supraventricular and ventricular arrhythmias. This also increased the risk of cardiovascular mortality. Are you noticing that I'm trying to give you all the individual factors leading to increased cardiovascular mortality? One by one, just to make it as clear as possible. Are you following me? Okay. And another risk is also pulmonary hypertension, meaning that the vessels are contracting in the lung. This is called pulmonary arterial hypertension, and this is observed also in patients with non-autoimmune hypothyroidism and in patients with Graves' hypothyroidism. Why is it this case? Because the endothelial cells are contracting themselves. They are not relaxed anymore. This is autoimmune induced. And indeed, if you look at patients with Graves' hypothyroidism, you can reduce the pressure, the systolic pressure in the pulmonary arteries when you give them antithyroid drugs. Just give them methimazole, wait a few weeks. If the patients normalize the thyroid values, the levels will normalize. The levels for systolic arterial pressure. And we have done this and published this already several years ago. Not only the function of the heart is changing, but also the structure, the morphology of the myocardium and of the heart valves, myocardial valves, mitral valves, aortic valves. What is going on? The valve thickness is usually 1 millimeter, 1. In patients with autoimmune thyroid disease, the thickness may approximate 10 millimeter, 10. It's like a centimeter. And this is observed in patients with autoimmune, Hashimoto, and Graves' disease, in contrast to controls. This has been published in Nature. So you would say, why is it this case? How does this happen? We do know that the myocardial and mitral valves are composed by endothelial cells. Endothelial cells are like fibroblasts. Endothelial cells have TSH receptor. TSH receptor, the intergenes in the thyroid, is also present on the surface of the endothelial cells. So, why I'm explaining, thank you for giving me the light. It worked. Okay. So the TSH receptor is on the surface of the endothelial cells. And what's going on? Very simple. The antibodies, the TSH receptor antibodies, bind to the TSH receptor on the surface of the endothelial cells and lead to hypertrophy of these cells and to activation of these cells. And these cells, these endothelial cells, are like fibroblasts. They are producing mucopolysaccharides. These mucopolysaccharides are hydrophilic. Hydrophilic means it attracts water. Water, well, swelling or edema. So the thickness of the valve is increasing. And you have a very thickened mitral valve of around 1 centimeter. The danger of this sickness is that you have a prolapse. And the prolapse is increasing the risk of thrombosis. Are you following me? Okay. And the complication of the increased thickness of the cardiac valves is valvular regurgitation, endocarditis, cerebral embolic events, and even arrhythmic sudden death, published in the New England Journal already 20 years ago. So all these individual factors explain the increased cardiovascular mortality and morbidity. So we have cardiac arrhythmias, we have an increased heart rate, we have an increased cardiac workload, we have also an increased left ventricular mass with myocardial hypertrophy, we have also pulmonary arterial hypertension, atrial fibrillation. This all leads to stroke, angina, myocardial infections, heart failure, sudden deaths. So you would say, oh, should I actually explain this to my patients? Well, you don't have to tell them the whole truth, but you have to be cautious and to know and to be informed what could be happen if your patient is not treated. So a patient with persistent atrial fibrillation has to be treated on time. You cannot send him back home. Okay? So let's switch now to the next point, the next topic, hypothyroidism. And I will give you an anecdote. 10 years ago, I was working at the emergency cardiac unit and the emergency room in our university hospital. And a lady came with heart failure and lung edema. History told us that this patient had thyroid surgery and she was on T4. But this lady was not compliant. She was not taking any T4. Why? Well, she was not taking any T4. She forgot. So the patient had a TSH of 70 milliunits per liter. Is it high? Yes. And the patient had lung edema, and she was put on diuretics. She came also to the coronary units. We treated her, and she could be discharged 3 weeks later, much better. So we told her, please lady, take your T4. Okay? Unfortunately, she didn't take her T4. She came back a couple of weeks later with the same picture, with the same, actually, symptoms and signs. This shows you the close relationship of T4, of the thyroid and the heart. Are you following me? So, what are the symptoms and signs in hypothyroidism? Fatigue, cold intolerance, bradycardia, hypertension, dyspnea on effort, and if it's severe, heart failure, pericardial and pleural effusion, and coronary heart disease. So you'd say hypertension. Why is it the case? And why? What is the impact on the cardiac function? Let's go into detail. What is happening if you have hypothyroidism is that the endothelial cells of your vessels cannot relax anymore. The vessels are stiff. They are not relaxed. And the relaxation of the vessels is very important for the diastolic tension. The diastolic levels are always dependent on the relaxation of the vessels in the periphery. The systolic blood pressure is dependent on your cardiac function. If your pump is working, this will increase the systolic levels. If your peripheral vessels are stiff and contracted, this will impact the diastolic levels. Why are the vessels so stiff? Because the endothelial cells cannot relax. Missing T4 leads to stiffness of the vessels. T3 and T4 relax the vessels. Relax the vessels mean opening the vessels. Opening of the vessels mean lowering of the diastolic tensions. Are you following me? Okay. So, one of the main reasons for diastolic hypertension is hypothyroidism. One of the main reasons for systolic hypertension is hyperthyroidism. Hyperthyroidism increases the motility of your heart and the action of your heart. So the systolic levels are high. If your vessels are contracted and stiff, you have diastolic hypertension. This is important to actually understand. And the systemic vascular resistance represent and mirror the relaxation of your vessels, leading to decreased heart rate, decreased stroke volume, decreased contractility, and having an impact on cardiac output. So, the opening of the vessels is very important for your actually cardiac motility and for the cardiac output. Should we also go more into detail just to explain to you why cardiac output is decreasing in patients with hypothyroidism? I will try. Hopefully not too much details for you. In patients with euthyroidism, you have enough T3 and T4. As all of you know, T4 does not enter the cell. Only T3 enter the cell. T4 is called prodrug. T3 enter the cell and goes to the nucleus. T3 stimulate the action of an enzyme called the calcium ATPase of the sarcoplasmic reticulum. This enzyme is responsible for the calcium uptake within the sarcoplasmic reticulum, meaning that you have enough calcium which is responsible for the action potential, the contractility of the heart. So everything is dependent on T3 and on the calcium uptake in the sarcoplasmic reticulum, leading to enough action potential. This is the case in euthyroidism. Let's have a look now at hyper. Here you have too much T3, meaning that you have more calcium entering the cell, this sarcoplasmic reticulum, and your action potential will be higher than here. You see the difference? So more T3, more stimulation of the calcium ATPase of this enzyme will increase the uptake of calcium in the sarcoplasmic reticulum and increasing the action potential. Let's now have a look at hypothyroidism. In hypothyroidism, you have less T3, and this enzyme, in contrast to here, is not activated anymore. You have less calcium uptake in the sarcoplasmic reticulum, meaning that you have a lower concentration of calcium and a lower action potential. So this is normal, this is too much, this is very few of calcium. So calcium uptake depends on the activity of this enzyme and the concentration of T3. In a few words, this is the explanation how the heart is working in hypo and in hypothyroidism. The myocytes depend on the entry of T3 in the cell. And only T3 has an impact on the cardiac function. T4 is a prodrug and stay outside. We say in Latin, anteportas, outside. So in a few words, calcium handling and calcium uptake within the sarcoplasmic reticulum explains the impact of the thyroid on the heart. Other risk factors for cardiovascular mortality in hypothyroidism. This is a very large study, 25,000 people in Colorado, showing you the clear correlation between TSH and cholesterol. The higher the cholesterol, the higher the TSH, the higher the cholesterol levels. Can you do? Okay. And this explains why patients with hypothyroidism have a twofold increase risk for atherosclerosis. If you perform a study looking at the carotis intima thickness with ultrasound, there is a clear correlation between the TSH level and the carotis intima. Of course, you have an increase also of the total cholesterol and low LDL cholesterol, but clearly the thickness of the intima, of the carotis intima, depends on the TSH levels as shown in the study already 10 years ago. Not only cholesterol plays a role, but also smoking. So you would ask me, why is smoking so important? If you divide your patients with hypothyroidism in smokers and non-smokers, you see differences. What are the differences? You see that the TSH levels in smokers are 68% higher in smoker than in non-smoker. Do you have an explanation for this? I will give you the explanation. If you smoke, iodine cannot enter the thyroid because we have the so-called iodine pump. If you smoke, you are blocking your iodine pump, meaning that there is no iodine entry in the thyroid cell. If you don't have iodine in your thyroid cell, you don't have synthesis of thyroid hormones. So you are aggravating, you are exacerbating the paucity, the concentration, the low concentration of iodine in your thyroid cell. This is why the smokers have always severe hypothyroidism in contrast to the non-smokers. And in line with this, the level of cholesterol is always higher in hypothyroid smokers in contrast to hypothyroid non-smokers. 28% higher in smoker in contrast to non-smokers. So smokers renders hypothyroidism more severe, increase the cardiovascular risk in comparison to non-smokers. If you look at patients with hypothyroidism and measure the LDL levels, the oxidized low-density lipoproteins, they are maximally increased in overt hypothyroidism, but they are also significantly increased in subclinical hypothyroidism in contrast to controls. If you treat these patients with T4, you decrease the rate of oxidized low-density lipoprotein. The oxidized low-density lipoproteins are heavily atherogenic for the vessels. So this is a very high increase, a very high risk factor. And this is very well known as a metabolic study published in the GCN. If you just have a meal, and if you take a group, euthyroid group here, and a hypothyroid group, just take a meal, and you see that your plasma glucose stays elevated in the hypothyroid group in comparison to the euthyroid group. And also the plasma insulin stays elevated for nearly 3 hours in those hypothyroid patients in contrast to euthyroid subjects. But look at this, look at this. Plasma triglycerides, 3 hours, or even more, 300 minutes, like 5 hours. Look at this. This is the level of the plasma triglycerides after one meal in hypothyroid patients versus or in contrast to euthyroid subjects. So why I'm showing you all these details? We say in German, facts, facts, facts. It is dry. I accept this. But if I don't present you with facts, it is for me not scientifically convincing. So what I'm trying to deliver, I'm trying to show you facts, meaning that usually your metabolism is lowered in hypothyroidism, increasing the level of circulating lipids, triglycerides, and also plasma insulin in patients with hypothyroidism. Does this impact atherogenesis? Yes. Does this increase cardiovascular morbidity? Yes. Does this increase the risk for myocardial infarction? Yes. Okay. Same story, and I don't want to lose too much time. You have a clear correlation between TSH levels, hypothyroidism, and BMI and obesity. This is a very large study from Norway, published a couple of years ago. So let's sum up. What I have showed you in patients with hypothyroidism is an increased level of cholesterol, total and LDL cholesterol. Evidence A mean the highest scientific evidence. Also an increased diastolic blood pressure. And an impact on endothelial dysfunction. You have no relaxation of vessels anymore. Smoking impairs thyroid hormone actions. And because of time, I didn't show you enough data on an increase of homocysteine, which is a clear risk factor for cardiovascular morbidity, CRP, and coagulation abnormality are all observed in patients with hypothyroidism. So you would say, okay, I gave my slides for integration here, and this changed the layout, so okay. Okay, so subclinical hypothyroidism and the risk of heart failure. This shows you also, all these facts have shown you the impact actually on the heart failure. If you have patients with subclinical hypothyroidism, especially if you have levels TSH above 10, you will have an increased hazard ratio, meaning that you may have an increased risk of heart failure if your patient are severely hypothyroid. Not mildly hypothyroid, but severely hypothyroid. This is a meta-analysis. And also, you have a risk of coronary heart disease and mortality if your TSH is above 10, coronary heart disease mortality, and total mortality may be increased, especially the cardiovascular mortality is clearly increased, significantly increased in those patients with subclinical hypothyroidism. So you would say, so what? You have showed us so many slides. What are your conclusions? The conclusions are the following, dear colleagues. This is a very nice stratification published in Endocrine Review, telling you the following. If you are hypothyroid and have a serum TSH below 10, as I showed you, the major risk is, or happens, if you have a TSH above 10. If it is below 10, the question is, do I have to treat these patients, yes or no? So this is the answer. If you have a high background cardiovascular risk, patients with a TSH below 10, with a documented diastolic dysfunction, diastolic hypertension, dyslipidemia, diabetes mellitus, smokers, then go for T4. Give them T4. If your patients have a low TSH, but they have normal cardiac function, normal arterial pressure, normal lipid profile, normal glucose metabolism, they are non-smoker, they have a low cardiovascular risk, just observe them. You don't have to put them on T4. So all the facts tell you that you can differentiate between patients who need T4 and patients who don't need T4. And this has been actually followed in the guidelines. If you look at the American guidelines now, this is exactly what they are telling you. Again, if you want to recommend treatment, if you want to follow the guidelines, you need the facts. You are based on facts, otherwise you cannot do any recommendations. All in all, if you are treating patients with hypothyroidism, this lady had a TSH of above 100. This lady had a very enlarged heart. She has microvoltage. She was suffering of depression. And she had an increased cardiovascular mortality. It was an easy job to help her. It was an easy job to increase her quality of life. It was an easy job to follow her. What do we do? Just give her T4. You see that you are actually helping her heart silhouette. She has now a normal ECG. She lost weight. The depression was gone, and her quality of life was now increased and normal. Thank you so much.
So nice to hear. I would like to ask you about the screening. It's going to be really difficult to find someone with the clinical signs and symptoms to have subclinical hypothyroid. Even for the offered for the clinical hypothyroid for us, it's not so easy to find that kind of patient. And now you talk more about subclinical. How do you do that?
Very good point. I think that there's not a big difference between Europe and Asia. I don't think that the patients who come to you and tell you, doctor, I have subclinical hypothyroidism, they don't have any symptoms. So screening means for me that you have to think about the risk factor who can develop actually subclinical hypothyroidism. So as we shown before, as we have learned from the previous talks, those patients who have family history, those patients who have TPO antibodies, those patients who have, let's say, a history of radiation, may develop subclinical hypothyroidism. And I will go a step further. I always do screening for TSH and for subclinical hypothyroidism in all females in postmenopausal age, because the risk for subclinical hypothyroidism is increasing after menopause. I always perform TSH in patients who have lipids, dyslipidemia. I also do for TSH screening in females who like to have children, and if they have problems of menstruation. I also go for TSH screening if the patients have depression. And I go for TSH in patients who are obese. So these are, let's say, the indication to look if subclinical hypothyroidism may be present, because nobody will come to you and tell you, I have subclinical hypothyroidism. And the prevalence of subclinical hypothyroidism is increasing dramatically in the United States and in Europe.
Professor have the second talk after my talk.
So if you have any other questions, please save at the second talk.